Morning and welcome to this episode. I sincerely thank Professor Shobana and her team for giving me this opportunity to talk something on introduction to palliative care. And I believe in me. This is our institute, Mahatma Gandhi Medical College, Sri Balaji Vidyapeeth. So I was thinking why I should be given this topic. Why I should be given this topic? Should I take this topic? Am I a big palliative care specialist or not? Maybe we are running a free palliative center in the name of Anna Aduragam in Timakodi, near around 100 kilometers from our institute. We are running, and this is mainly run by ST hospitals, and I am the treasurer of this. Probably this may be the lead to give me this topic in palliative care. So this is Cicely Saunders was the champion of this palliative care, and here is our champion, Professor M.R. Rajagopal of Calicut, who is dedicated to, and his life belongs to pallium. So here you can see the red quote, live until you die. This may be the core essence of palliative care, live until you die. Now, what is palliative care? Palliative care is the active total care of patients with life-limiting disease and their families by a multi-professional team when the disease is no longer responsive to curative or life-prolonging treatment. I will come back to each and every word of it in the next sessions. Hospice care is often used, but some countries tell community-based palliative care. Now, which cases have to be taken to this palliative care? Terminally ill cancer patients, terminally ill heart failure, liver, lung and disease, dementia, possibly some stroke, amyotrophic lateral sclerosis, and Parkinson's disease. These may be the cases, but the prime priority comes to malignant illness. Whenever we take up the palliative care institute, we should be clear to explanation to patients and attendees, because somebody after taking up a terminally ill care patients may tell why you are not giving chemotherapy, why you are not giving radiotherapy and all. This is all not about this. This is a multi-professional team approach to live better. That is what is the comprehensive idea about palliative care. You should explain to the patients. Now, sometimes the patient attendees will go off because the patient has written the will to whom, which has to go to whom, like my cash, my FD has to go to my daughter. All these things have been done means sometimes the attendees may not be attendees at all. Now we will go to the definition again. Okay. The palliative care is the active total care with self-limiting families, multi-professional team when the disease is no longer responsive to curative or life-prolonging treatment. Now we have an end-stage cancer breast. Now you do a good pain relief. You talk to them. You talk to the patient's other side of it and let their mood get upbeat. Do ask them to do prayer. Let their economy flourish and give a handshake and be a part of the patient. This is all is the definition. Again, you totally give. This is the end stage. Now it is not curative or prolonging treatment. You are a multi-professional team by pain relief, food and beat, prayer, economy, etc. You are giving both to patients and sometimes to their families. This is what is the palliative care. Now we may give good nutrition, we may make them to walk, we may help them to do prayers, we may take the patient to temples, and there may be some good lectures, dances, etc. So this is what do you mean by let them live till die. Live till die. This is the concept of Cicely Saunders. Now we can see our institute has got a River Kaveri background, and this is probably a cremation ground also we have very nearby. And if there is some problem, we cremate them and send a parcel of whatever sambal to the dentist by courier also. And we do all things. Sometimes these haircuts to patients and make them good like. And I know this patient has got into some charming look later, and she died after 1 week. No, it's a wholesome care. This is what I want again. Now you see, there are some patients, there are some attenders, there are some palliative care doctors, there are some staff nurses. Now you see these are the patients, and you can see these are some of the patients, and this is this patient having balloons. Now there are a lot of other things. You can see the Navaratri Golu here. We conduct and make some music festivals and all. Here you can see the music festivals. And also we do the Republic Day celebrations with some things. Flag hoisting with the patients, deceased, all these things. I have already told multi-professionals. Who are the professionals? Doctors, palliative care physicians, nurses, psychologists, their families, nutrition experts, spirituality, and going inside of what is needed for the patient. This is what is a multi-professional approach. Without a psychologist, a palliative care physician may not be 100% effective. We should understand that it is no longer curative or significantly prolonged lifespan. That is what is in the definition. Now, if you give a chemotherapy, this patient is going to get cured. Or if you're going to give chemotherapy plus radiotherapy, it is going to significantly prolong lifespan. For example, 2.5 years. So these patients don't come under palliative care. So it is a combination of physical, you had handshake. That is very important. Social, spiritual, psychological, and a lot of people work like this. What are the 4 pillars of palliative care? Pain relief and symptom control, emotional care, social care, spiritual care. See, for example, some points which I might have touched will come little later also. But I will go little practically with our experience rather than so many things given in textbooks. Now you see these are the drugs. For example, pain relief is a must. It's a part and parcel, essential part of palliative care. There should not be any pain. You see, you can give non-opioid adjuvants, go on to increase opioids and then strong opioids. And you can see this is the patient of CHE which I gave mandibular block with neurolytics, and this patient lived for 3 to 6 months without any pain and died. So this is what is important. Pain relief. We can give blocks. We can give even acupuncture. So these are the drugs. So palliative care center should have easy access to narcotics. Symptom control. Yes, this is pain. Yes, okay. Other symptoms, patient can have vomiting, patient can have itching, loss of time, diarrhea. So it is not curative treatment. You just give ondansetron. You just give some antihistamines. You give some pantoprazole. All these things, diarrhea. So all these things come under palliative care, but it is not curative treatment. They may have suicidal thoughts, negative thinking, and not eating properly. Very important. This is loss of appetite and not eating properly will go together. Whether this is a somatic symptom or psychological symptom has to be assessed. Emotional care. Touch the patient. This is very important. Give him or her food like this. Set a comforting mood for this. Unless you handshake, touch the patient. Go inside. Sit in this trolley. Your palliative care seems to be less effective. Sit in the back and give them the pat. This is very important. Some people may play music at a low volume and just relaxed. Involve the dying person. involve the dying person and make them do. Now you see, this is a patient with birthday. We all went to the hospice and sang a song in praise of these persons who are
வளர்ந்து வாழ வேண்டும். அன்பு வேண்டும், அறிவு வேண்டும், அன்பு வேண்டும், அறிவு வேண்டும். அன்பு வேண்டும், அறிவு வேண்டும், பண்பு வேண்டும், அறிவு வேண்டும். எட்டு திக்கு புகழ வேண்டும், எடுத்துக்காட்டு ஆக வேண்டும். எட்டு திக்கு புகழ வேண்டும், எடுத்துக்காட்டு ஆக வேண்டும். உலகம் பார்க்க உனது பேரை நிலவு தாளில் எழுத வேண்டும். உலகம் பார்க்க உனது பேரை நிலவு தாளில் எழுத வேண்டும். சக்கரை தமிழ் நல்லி தாலாட்டு நாழ்க வேண்டும். சக்கரை தமிழ் நல்லி தாலாட்டு வான் சொல்லி வாழ்த்துகிறோம். பிறந்த நாள் வாழ்த்துக்கள், பிறந்த நாள்
His fame should be written in the moon. Those things come in that words Tamil. So these are all the must. Social care, getting out of bed, getting dressed is very important. Getting new dresses. See, for example, old dress with this thing will come down on the mentation also. Going to the toilet and showering, cooking and eating. Sometimes we make them to cook. Seeing friends and families, using public transport, keeping fit and active as far as possible. This is very important. Getting out of bed, getting dressed, have resting, get coffee or milk or something else, going to the toilet, get a shower. Make them do all these things. This is our hospice persons or palliative parents taken to Ponniyin Selvan movie. So sometimes you can hear a patient saying, what is this? I'm having terminally ill care. I feel all hope is gone. What is left for me to care about? What I have done to deserve this? These things are moral distress. So sometimes we may need specialist skills in spiritual care. So social care, we have told. Spiritual care, we have told. First was what? Drugs, pain relief, other symptom relief like nausea, vomiting, diarrhea. The second is social care. The third is spiritual care. Now you see, this is the patient. This is the patient. These are all inmates. Now we are celebrating Diwali. Now we are celebrating with inmates having these type of dresses. So this is what is known as spiritual care. Sometimes we make them to go to temple visits. We have a special prayer hall. Palliative care need in India, systematic review and meta-analysis. Now you can see this article was published in 2023. So the need is 6.21 per thousand. Ages more than 60, female South India it is more. So we need more. The total number who need is likely to be 6 million people per year. Where are we? 6 million people per year. Now we see the countries ranked by the quality of care. UK, even see Sri Lanka is in 16. We are in number 59 by way of quality of enough life care. We have to move up here at least to 30, 40 range within 2 to 3 years. We need to popularize this. There is no, what is palliative care is not known to many people. I will say with authority that many of the people, doctors, even people working in palliative care, nurses, don't understand the bigness of palliative care treatment and their regional, socioeconomic, racial, ethnic groups influence access. Some region may not accept palliative care. Some caste may not accept these things. So they should be, care team members may be reluctant to discuss. See, for example, a patient is having a terminally cancer. Now we are going for a palliative care treatment. Their treatment may not accept because their hope is lost. If I say to the patient, you are terminally ill, you are gone, their hope is lost. That is where even the palliative care physicians are afraid of. Now we need family support. I have already told. We are conducting a meeting of this. This is a fellow who is having Cushing's muscle trophy and he cannot walk. We have given the chair, and this fellow, family members are also admitted with terminally ill illness. Now the advantage is this fellow is known to know knowledge of computers. So we have appointed him as the manager of this, even though he is an inmate. We have appointed him as a manager and we are giving him some salary. So this is what is family support and encouraging them to the core. Now, why we need palliative care? Now we have an understanding what is palliative care. Now we have an understanding what are the patients who come under palliative care. What are the 4 pillars of palliative care? Why we need this? Probably this slide should come earlier, but unless we know what are these things, we will not understand why we need. Live better and longer with less symptoms. Spiritual and emotional well-being. Identification of life goals and advanced care planning. Now, we know just the terminal care ills, we can dedicate and finish all these other works. Increase the satisfaction, less hospitalizations. For example, you are in a hospice taking orphan and taking some barrier. You don't need to go to emergency rooms on and off. That is very less. Less burden on caregivers because your son and daughter-in-law may be working in Swiss bank or this bank and they may be very busy, so they are given less burden. They come weekly once. They spend here on Sundays. That is very important. Thus, the ill feeling may not be there, but they work also, and we take care of the patients. Decreased medical team distress. So there are certain things which makes palliative miscellaneous thing. What is palliative day care? They come on 1 or more days a week to the center, attached to another service or on its own. Now they are not hospital inside the palliative care center. They'll be nearby. They'll come 1 or 2 days per week, and they have other things. For example, they may have good pain relief drugs, and they go with morphine tablets, and they come if they have symptoms, they will get some injections or some types of other recreational activities. They will be shown paintings, they will be created, and these things, the music and all. This is about palliative day care. What is outreach clinic? So our center is located here. We go in a van to go at a palliative care at a home. We go as a team and do a palliative care at a home. Do this. They may not be interested in admitted care. They may be at home. Some part of the palliative care has been already to the attendees. Some part, for example, we go with a psychologist. We go with some other people who knows music. All these things we go and fill them and make them to live. But sometimes we are going from, for example, from Pondicherry to Kadalur or Pondicherry to Banrutti. In between there is a Kadalur, or in between there is a village, Kurinjipadi. There may be some 2-3 patients on the roadside which we may need to treat. These are all the miscellaneous things. Ours is free of cost, but we need all people to motivate. As soon as they get malignancy, we should need to motivate for insurance plans, and they should get insurance for palliative teams and palliative care. So the problem is they may be admitted for 3 months, 2.5 months, 4 months, 5 months. Some people have been here for 1.5 years with terminally ill colonic cancers. On an end note, I want to show this video. For example, there was a patient with terminally ill malignancy. He was crying like that only. Whatever we make a psychological support to him, he was not awake, he was not answering very well. So one day he told, even though I have become this profession and retired, I actually wanted to become an army man. That is what he told our team. Then what we did was, now on a Republic Day, we called a lot of NCC cadets or NSS cadets from the schools and colleges. See here. Now, this is the fellow who is a terminally ill malignant patient. He wanted to become an army. Now, he was made to, he did not reveal this.
நீங்க கூட இருந்துக்கோங்க தேவி.
Now, I will tell you one truth. As soon as this wish was satisfied, he died within a week. So this is what our plan life. We don't have cancer patients. We have persons or human beings living with cancer. This is what is the aim of palliative care. Thank you all. Thank you for the wonderful opportunity given to this by me, by the Institute of Salatogenesis. Sri Balaji Vidyapeeth. Thank you, one and all.